Welcome everyone to our stakeholder engagement event. It's regarding the Appliance Prescription Management Service, or stomas and catheters in general is what we're talking about today. I'm Anoop Shah. I'm leading on this from the Meds Management Optimization team from the ICB, and I've got some colleagues here from Bullens, Paul Gunson and Jeremy Taylor, who will present a little bit later on around their part in this service really, and how the service will operate and the sort of the basic stuff that you guys will need to know when we transfer these patients over. So we're just going to talk through this service. The service is being recorded and it will be available in a few days for colleagues that either can't make it on holiday for whatever reason. You can share the link with them and they'll be able to view the recording and give them an idea of what's going on. If you could keep your mics on mute throughout the presentation. There'll be times for question and answer at the end of Bullen's presentation, and we'll work through that. Any questions in there? If you've got questions that you sort of think of while we're running through the presentation, if you put them in the chat, and my team will try and answer them as we go through the meeting, and then obviously we can pick up anything at the end of the presentations from yourselves. I think I think that's the sort of housekeeping stuff. Okay, so first of all, why are we looking at this service? What's the reason for having an external contractor taking on the work of prescribing for stomas and catheters within the ICB? And really, there's quite a few reasons why we've gone down this route. We have been working on this for a while. We started work on this last year in conjunction with NHSE, and we were looking at ways to improve the stoma and catheter service appliances for patients within the southeast region, and we wanted to have a provider that could cater for everything really, and Bullens met the criteria, and we're about to sign the contract with Bullens to make them officially the appliance management contractor for Bob ICB. We have been working on this with Friendly as well, because obviously part of the new footprint will include East Berkshire, and we have been working hand in hand with them as well when we have been discussing the provider and details around that. We've seen a consistent rise year on year on the prescribing spend for urology and stoma appliances across our system. A lot of this prescribing does originate in secondary care or third-party providers in some cases, and it's not always down to primary care to prescribe these items ongoing for new items for these patients, but you do get to pick up the prescribing responsibility once the patients have been discharged from hospital into your care. And what we're proposing obviously with this service is that prescribing and the responsibility of the appliance care for these patients be taken over by Bullens, our third party provider. We know there's been a lack of sort of consistency in clinical governance around appliances, the choice, the quantities that are prescribed, and sometimes it's with the influence of manufacturer-sponsored nurses within the trusts as well. And we're trying to obviously look at all of those aspects in turn and provide a consistent approach to how the prescribing is carried out, and sort of look at ways where we can improve.
I'm just trying to put you on speaker. Why is that?
Sorry. Oh, thank you. Yes, we'll be addressing all those issues, and we have been working with the trust, looking at all of these cases as well. One of the other reasons, obviously, is the recent GP collective action as well that wants to cease prescribing of certain items in Part 9 and Part 15, where stomas and catheters sit within the drug tariff. And we're obviously trying to have a service in play which will take over the prescribing of stomas and catheters that fall within those parts of the drug tariff. So that's why we've introduced this new service. It's a new streamlined service as well. It benefits both the patients and the practices and the trusts going forward. Okay. Thanks. Next slide, please. Okay, so how will the service operate? Patients basically are referred in by healthcare professionals directly into the service, and Bullens will talk through about how the practices obviously do all of this in their presentation. And this is just a brief overview from our side. They'll give you a little bit more detail on that. But basically, any patient that's been discharged or will be discharged from the hospital, trusts or specialist services will be referred into Bullens services from our go live dates. We'll send those through to you individually once they've been confirmed, but we are looking at possibly the 6th of October as our first go live date across Bob ICB, which is the first Monday in October. Referrals tend to be processed by Bullens on a daily basis, Monday to Friday, 9 to 5, and they try and get through the referrals within 2 working days. So patients that have been transferred over, new patients or existing patients will be picked up by Bullens within that time if they're referred through by a healthcare professional into their service. All the patients will get a welcome call within 5 working days from Bullens, and they'll talk through the service, the process of what the patients need to do, how they can order their medication, the way they want to order them. All of those things will be discussed with the patient on an individual basis, so we can meet the needs of the patient directly. Patients, any incomplete or suspicious referrals will be flagged to the specialist teams, and Bullens will push them back into the either the trust or GP practices. And it may be that the patient's not a true stoma catheter patient. It might be a temporary supply that they've had, things like that, or if they haven't got the full details on the patient and what they should be prescribing for the patient, they'll be referred back for clarity. New patients to the area need to be referred, obviously, by the GP. So if you've got new patients that have transferred into our area, they obviously wouldn't have gone through any of our trusts. They would come straight through you to the GPs. They'll need to be referred into the new service. To help with sort of standardized prescribing across Bob, currently we don't really have any formularies for stomas or catheter care, urology care. So we're working on an ICB formulary that we've created around stomas and catheters that's been circulated. It's trying to make the products that we have in primary and secondary care so that we marry up, so we don't have an issue with prescribing primary care, and the choice of products are cost effective and clinically appropriate products. Bearing that in mind, we know that not all the products will work for every single patient, not one size fits all. And there is a little bit of give, obviously, on the formulary, because we still want patient care to be paramount, and we want the right product for the right patient. And that's what we're aiming for with this service as well. Okay, next slide. So what does it mean for GP practices? So we're hoping that it's going to free up some of your capacity within GP practices. The idea really is that you're prescribing for these patients on a day-to-day basis. It's taking up your time. A lot of the time, GPs or non-medical prescribers within practices are not specialists in this field, and they end up having to prescribe products that probably fall outside of what their comfort zones are. So the service will have prescribers that are specialists either in the urology or the stoma fields, and will manage the prescribing of these products. So it takes the burden away from GP prescribing. It also hopefully reduces the pressures within the practices in some way to help reduce the workload within the practice for yourselves. There's hopefully, by having specialist prescribers at the other end, where they are, the Bullens will not just issue a prescription based on a request. There's certain criteria that they'll follow, and hopefully what we plan with this service is that patients that need a little bit more support will get picked up, and in turn will hopefully reduce some of the emergency attendances that we end up in hospitals. They end up in A&E because their stone was leaking for whatever reason. They can't really figure out why it's leaking, or the skin's become weeping for whatever reason, may have become infected. So we're trying to prevent those happening in the first place to reduce the burden in secondary care. And obviously in turn it will reduce the burden in primary care to an extent as well, because those patients will end up back into the GP practices for continued prescribing of external products. We also hope with the introduction of the service that will have a positive effect on the quality of patients' lives. Patients with these sort of problems are normally face difficult challenges. Sometimes they're embarrassing and often hidden by most of the patients. Having regular access to specialists who they can talk to about what their needs are, the issues that they're facing on a daily basis from specialist teams, certainly hopefully will make a huge difference in terms of patient confidence and well-being. So we're hoping the service will help support all of this sort of work in the background as well. The specialists hopefully will be able to spot early warning signs. If you've got a recurring leakage, or you've got a UTI, they've got skin damage, sometimes is a sign of sort of more complicated things appear further down the line. So with the intervention of the specialists, when the prescriptions are ordered, when the questions are asked of patients, they can hopefully reduce the long-term complications of this. And obviously this helps us monitor prescription requests carefully, because patients will get asked, questions about what they hold in stock, why they're ordering certain products, if they're ordering products fairly early. If they've ordered 32 weeks ago and they're ordering another 30 bags, it might be a sign that they're changing the bags more often. So they'll get these sort of questions asked. It will support sort of the prescribing, help support reduce waste, and obviously it'll be better use of our resources. So if it's not only clinically safer, it's also obviously financially safer as well. So that's what we're trying to look at in terms of benefits to patients and GPs and reduction time within practices. Okay, next slide. So each patient will have can order their products by phone, app, email, or so there are a variety of modes that they can have. They can even have a callback system. So if patients are struggling, considering sometimes the age group of the patients that we're dealing with, who may not be as heavily involved with IT as some of the younger generations, they might struggle with an app, and therefore we do have other ways that the patients can order. Like I said, they check the current health status of each patient with a regular follow-up call. They'll get reviewed on a regular basis by the new service, which in turn obviously we're hoping will lead to any reduction in emergencies and hospital admissions, which we sort of already talked about a little bit. I mean, I think when you look at this, we're trying to be proactive, which is what obviously the NHS plan is to try and prevent, to be a little bit more preventive rather than reactive, and hopefully the service will help support with that goal for the NHS. It also, I mean, we talked about the confidence as well, but also patients, it gives patients a little bit more control over what's coming through. Currently, there are a variety of providers that order on behalf of patients, and you get a lot of third-party requests coming through the practices as well. And then these end up being stored at the patient's home, and we've had feedback from nursing teams, you know, that basically some of these patients have got a box room full of products that either they're not using anymore or they've stockpiled because just in case they run out. There's been a big build up since COVID of patients trying to store a lot of products because they're worried they won't get their products. And again, these group of patients are probably more feel that they are more at risk and therefore tend to have a little bit more stock than other patients would probably have. And we're trying to obviously support with that, trying to stop the storage space of these supplies being used in the patient's homes, reduce the quantity that's being prescribed, and sort of provide assurance that, you know, if a product is not going to be available, we'll have an alternative product for them that hopefully will be suitable for them as well. So, you know, it's not about just getting the product into the patient's home, it's about getting the right product and assurance to the patients as well. One of the main questions we've had asked around this is, especially from the trust, is do the patients need to change the way they're receiving their current medication from the provider that they've got in play at the moment? So their DAC, for instance, their patients do not need to change their DAC. They can have the current DAC supply, whether it be another DAC, whether it be their pharmacy that's doing the provision, whether it be the practice that's doing the supply part of this. So they don't need to have that changed at all. They can continue to get the supply from their current provider. The only difference is the prescription is going to be managed by Bullens, who will send the prescription to the current, whichever DAC needs the prescription. So I'm hoping, from what I've said, you sort of get an idea that the service is really patient orientated. It helps to reduce the workload within GP practices, and hopefully it offers greater control to us and to patients, improved support for patients, and hopefully lead to better outcomes overall for patients and practices and the ICB. Okay, I don't think there's any more slides, is there? No. Okay, cool. So really, that's just a brief overview of what we're planning to do with this service. I'm just going to lead to Bullens. There's a question from Michael. Michael?
Do you want to do questions now? Because I don't know if you're going to give us more information or not.
Yeah, but if we can do questions after the Bullens presentation, they'll give you more details, and then we can do questions if that's okay, Michael.
Oh, hold on.
Okay, thanks. I'm going to hand over to Jeremy and Paul, who are both from Bullens, who will continue with their presentation around the service. Over to you, Jeremy.
Yeah, thanks, Anoop. Just pulling my slides up. Let me know if you guys can't see those. I'm sure you can. So yeah, I'm from Bullen Healthcare. Thank you for the opportunity to present. I've got a couple of clinical colleagues with me as well, and as Anoop says, I'm sure there'll be questions at the end that we can field. A little bit just aside from the prescribing service and the offering that we will be commissioned to provide, to start with, a little bit about who we are. Because many of you may not have heard of Bullen Healthcare. So we currently run 5 similar services to this in other parts of the country, be that for urology patients or stoma patients, or urology and stoma patients, where we've been commissioned to provide what we call a centralised prescribing service. and we cater for about 15,000 patients across England currently. We have a substantial team of nurses, and that is a growing team of nurses. So hopefully that will provide confidence around the prescribing capability of the service. 11 of our current team are nurse prescribers, and that is literally growing on a monthly basis. And they are the specialist nurse prescribers who will prescribe for your patients. We are a dispensing appliance contractor. We're what's called an independent dispensing appliance contractor. So what that means is that we are not a manufacturer of products, which makes us largely unique in this particular market. We don't have a vested interest in a particular product. We do distribute a couple of fairly low volume products, but we're not a manufacturer. So it makes us product agnostic, which I think is probably one of the things that appeals to the ICB. Just from our perspective, as we move on now to talk a bit more about the service, generally speaking, this is as I say, we have 5 services elsewhere in different ICBs, but this type of service is provided in more than five ICBs by other service providers, and the primary reasons for ICBs choosing to go down this route is firstly around patient experience. The nurses who prescribe the products for patients in this case are all specialist nurses, so they are stoma nurses or urology nurses or continence nurses who have their nurse prescriber qualifications. And by having those nurses prescribe and by asking the questions that we do when we speak to patients on a monthly basis, it does help us to get a feel for where potentially emerging issues are occurring, and therefore gives us the ability to onward refer appropriately if needs be. Certainly in the other areas where we've got established services in place, when we've spoken and audited GPs in those areas, they've tended to be satisfied that this element of prescribing has been taken away from GP's responsibility. I think we're acutely aware that the range of products available in the drug tariff is very vast, and the categorization of products in the drug tariff is not easy to navigate. So I think it is being recognised generally as an area where a specialist prescriber is potentially a benefit to the patient. But what we also absolutely see and have seen in other services, that we do find that there is some waste in the system, and it's our job to make sure that waste is taken out and make sure that patients aren't overstocked with products or understocked, for that matter. And I'll explain a little bit more about how we do that. So we're right in the middle of mobilization, I guess, at the moment. What will happen is, if you think about being 2 cohorts of patients, essentially from a GP point of view, you've got existing patients who use urology and stoma appliances, and then in the future, of course, you've got new patients as their condition requires. So we're at the moment in discussion with the ICB around how we safely and securely transfer data from GP practice systems over to ourselves. We have an EMIS system that's being set up to house all the details of all the patients for the NHS Bob area. So my colleague Paul, who's our chief pharmacist, will talk about the process that we're going to go through in a moment around obtaining that data. But suffice to say, we're currently in the throes of ensuring the right IG is in place to make sure that data is transferred securely. So it's important that we get a really clear picture of all the existing patients who use these appliances. We will then make contact with those patients. We will send them a welcome letter explaining the new service, and we'll also send them a very detailed patient information leaflet which contains a lot of information around the new service. Critically important that patients have a clear understanding of what's about to happen from the go live date, and feel reassured that there's not going to be any disruption to their supply. So as Anoop said earlier, the target date for go live is currently the 6th of October. Got confidence level that will be achieved. So any new patients across the whole of the Bucks Oxford Berks ICB area regardless of discharge point, will be referred into the service from that date. In terms of existing patients, we've split the existing patients into 3 cohorts of GP practices as determined by the ICB, and the first cohort will go live on the 6th of October, the second cohort 4 weeks later, and the third cohort 4 weeks after that. So you're talking roughly a third of the practices go live beginning of October, a third of them beginning November, and a third beginning of December. That's roughly how it equates in terms of GP practice numbers and patient numbers alike. Obviously, if all we are doing here primarily at the outset is taking place of the place of the role of the GP in terms of generating the prescription. What we do is, having communicated with patients, we also then telephone patients once the service goes live. We introduce ourselves, we explain how the service works. We ask them if they've got any questions, having received the information we've already sent through to the patient at that point in time. And we talk to them about their preferred contact preferences with the service. Most patients on our other services opt to have us ring them every 28 days as an outbound call from ourselves. However, it's up to the patient how they wish to be dealt with. So they may say, I will ring you when I'm getting short of products, or I will email you, or I will complete the online ordering facility, or I will use the app that's available. That's really very specifically patient dependent. What we will go through, most patients we do end up speaking to, but even if we don't, we will go through the same process of checking patients that we're speaking to the right patient. If we are speaking to the patient, looking at the specific individual prescription line items for that individual patient. We will do what we call probably a fairly soft stock check. So, for example, if a patient uses a box of leg bags every 10 weeks, because there's 10 leg bags in a box, if that's a line item on their prescription, we'll ask patients how many they've got left. If they've got a box left, then clearly they wouldn't need a box of leg bags for the order that we're about to send to generate for them. So that's what we mean by stock check. It's making sure that we're not doubling up on stock they've already got in their own homes. We will ask them 3 triage questions, and they've been agreed with the ICB, and they will be aimed at really trying to understand if the patient's condition has changed since we last spoke to them, and spot if there is anything that we need to flag or onward refer to local specialist teams if we can see a potential emerging issue. It's a real advantage of this type of service. What we'll also do on every interaction with the patient is ask them where they want their prescription dispensed from, whether that be one of the vast number of dispensing appliance contractors that are out there, or indeed community pharmacy. So once we've spoken to the patient, the prescription will be generated by one of our specialist nurse prescribers, and that will be sent electronically to the patient's choice of dispenser within 2 working days, which is a KPI will be measured against by the ICB. Any clinical issues, as I say, that raise themselves when we speak to the patient, we have the opportunity to refer those back into the local specialist service, and we're going through an intensive engagement with all those local departments right now. Important to kind of say at this point, we are just talking about appliances here, so stoma, urology, and transanal irrigation appliances. What we're not talking about is any medication needs, which will continue to be prescribed by the GP as usual. Paul, don't know whether you want to just say a little bit about the kind of data transfer process that we're going to follow?
Yeah, thank you very much. So there is a small amount of work that someone within the GP practice will need to undertake. So you will receive an email from Anoop with the data sharing agreement to allow that data transfer to happen. And you'll also be provided with an EMIS search or a System 1 search, and effectively an SOP or a protocol to follow, which explains what needs to be done. I've done it multiple times myself on EMIS, and it takes about 10 minutes System 1, slightly more tricky. It takes a little bit longer. You're looking at maybe 15 minutes, but all you need to do is import these searches, run these searches, and then export the searches in line with the instructions from the protocol, and then send it via nhs.net email to the nhs.net email that we provide you with, which is for the service. Once we then receive that information and patient data from yourselves, we compile it and we look to register those patients on our own EMIS system, which is specifically designed for this service. After which point we can then reconcile what products patients are utilising, prescribed, and what they need. What I would recommend for yourselves is to make a note on the patient's record when they've got a stoma, to just say in a patient notes, oh, patient has a stoma, so that when anyone within the practice is seeing that patient for some of their comorbidities, you can at least think, oh, hang on a second, I know that Mrs. Jones has got a stoma, so I'm not going to give her oxycodone modified release, because chances are it will go right through and end up in a stoma bag and be of limited use. So that information is useful to have. However, what you don't need is ongoing knowledge of all of the various different appliances that said patient is on, because it doesn't impact their other comorbidities. It's more the fact that that patient does indeed have a stoma. So it's a small amount of work, as I said, 10 to 15 minutes to identify those patients, to run those searches, and send it across to us. But then moving forward, then any communications that you might have from the patient's dispenser about wanting to request an item, or something's out of stock, or the patient trying to order from yourselves, it's just nice and clear for yourselves to be able to go, it's not us as a practice, it is the service. So the advice to the patient will just out, or the dispenser will be, please contact the service, and the service will deal with out of stocks, etc., etc.
Yeah, thanks, Paul. I think a really important distinction when we do speak to your patients, we will be identifying ourselves as the Appliance Prescription Management Service serving patients for Buckinghamshire, Oxford and Berkshire. So it's not a Bullens phone call, it's a service phone call, because that's the service that we've been commissioned to provide. Just to last 2 or 3 slides, really, just to so you've got kind of some sight of the type of information we'll be sending out to the patient. So I know you won't be able to read what's on the left there, but that's the welcome letter that will go out with the ICB logo on to the patients, explaining about the service change with dates and contact details. Together with that will be a very detailed patient information leaflet, which is available in different translated copies as well, for local population requirements. But we include in that all the details around the service, what happens next, how you order your prescription, how that then gets dispensed, how to complain and compliment the service, and importantly any FAQs. We've used that elsewhere and it works really well for patients in terms of reassurance. We have a similar booklet that is available for yourselves and other healthcare professionals, which has got kind of very similar information in, but just tailored to yourselves rather than patients. Just penultimately, probably worth just pointing in the direction of how we measure the success of the service. I guess. I mean, obviously there are a number of KPIs that are built into the contracts that we've signed up to. I guess one of the key ones is patient satisfaction. What I'm showing here is on the left-hand side, this is from a service that's been established for just about 2 years in another ICB area. What you can see is that the patient satisfaction levels with the service started off at just over 75% when the service was first started, and now is peaking out at anything between 93 and 95% a month. So we measure this very closely. Every single patient on the service gets a chance at least once a year to complete a survey, a formal chance to complete a survey and tell us what they think of the service. What we generally see in all our services is that patient satisfaction goes up fairly quickly in a relatively short space of time. I think we acknowledge at the outset that this is a change for some patients. So some patients will be, well, everything was working fine, but ultimately it's about kind of explaining the benefits of this new type of service to those patients, and providing reassurance, and we will definitely see satisfaction increase over time. The graph on the right hand side shows us the general response rate we get to the questionnaires we send out, so we can qualify the satisfaction levels by saying that about 30 to 40% of patients that we send a satisfaction survey to do actually respond, which is quite a high response rate. This particular service, as I say, been running for just under 2 years. We've had 17 formal complaints in that time, despite the fact we've issued nearly 31,000 prescriptions to that patient population. I have to say most of the complaints relate to the delivery. And I think one of the really important facets that we have to describe and explain to the patient at the beginning is this is a prescribing service, not a dispensing service. So whilst the patients may sometimes have gripes about their delivery, that isn't ultimately always obviously the responsibility of the prescribing service. It might be that delivery's been carried out by another party, of course. So finally, what the next steps now in the 5.5 weeks left before the first proposed go live date is to ensure that all the appropriate governance is in place, which we're working with intensively with Anoop, and then ensure the onboarding for patients is as seamless as possible and they're well communicated with. We are already knee deep in engagement with local specialist nurses, through our clinical team and local NHS clinical teams to agree local process and protocols. So again, providing reassurance to specialist nurses about how the service will work. And you will receive some communication from us that specifically confirms go live dates by GP practice. And the same information will go out to both nurses, patients, and other stakeholders, which includes dispensing appliance contractors and community pharmacy.
Okay.
That was it from a Bullen perspective. Anoop, I don't know whether you want to add anything else on the back of what we've just shown.
No, so I think thanks Jeremy and Paul. I think we've covered most of it through this, and obviously over the next few weeks there'll be engagements, emails, and things that we'll have with the practices. So we can probably start doing in some of the questions. We're going to try and answer some of them. So Bina, over to you. What are our questions?
Yeah, hello everybody. Yes, there are a couple of questions, Anoop, in the chat box that I've attempted to answer, but it's quite useful just to hear the response out loudly, just to make sure that that I'm accurate in what I've said, and if there's any further clarification that's required. And we're going to say, so the transfer, first of all, each practice will have a date to when they're going live. Is that correct, Jeremy?
Yeah. Yeah, there's this, as I say, there's split into three. There's 3 go live dates proposed at the moment, beginning of October, November, and December, and each practice is allocated a date already. And Anoop's got all the details of those, because those proposed priority order were provided by the ICB.
Yeah, and then there's a hard stop date on the date that the data needs to be transferred to ourselves in order for us to be able to register those patients and get them on and live for that go live date. So if the practice have missed the hard stop date, then they will have to fall into the next go live.
Okay, thank you. And I think you explained about the practices will be provided with an EMIS or System 1 search and instructions as to what to do with that data. That will be part of the data sharing agreement as well. Hopefully, I think I've answered that correctly. Yes, we've done that on set up by. There was emergency prescriptions if patients have run out and need to supply as soon as possible. Should they be told to contact Bullen?
Yeah, if they contact ourselves, what we can do is we've got processes in place to escalate situations like this. So we can usually get a prescription across to their chosen dispenser within an hour of being made aware of it.
Okay, thank you. Matthew wants to know what date will our patients receive their letters telling them about the service, because they want to just warn their reception teams of what's coming.
Yeah,
that will be informed by the go live date or the cohort. So what we can do is we can look to include that as part of the information that's sent out. So cohort 1, for example, goes live on the 6th of October, and we will send the communications to patients just prior to that, but we'll confirm the actual date that patients will start to receive this communication for as part of that go live plan.
Will there be a letter that the GP practices will be sending their patients to inform them of the new service, so that of that continuity?
What we've done elsewhere and moving towards the digital first sort of priority is and strategy is posting some digital letters online to be able to direct patients there. So within Surrey, for example, practices have utilised AccuRx to send messages to the individual patients to say, please follow this link where you'll find more information about the new service.
Okay. Liz Hooker wants to know, will referral form be added to the documents launcher for EMIS referrals?
I'm not sure it is required, to be perfectly honest, because once we've done the initial data transfer of these existing patients, all of the new patients, the referrals will come from the clinicians or the hospital, the community teams who are initiating patients on these products. So GP practices will get a copy of the communication from these teams for information purposes, to let them know that a patient now has a stoma. But in terms of the practices needing to do that ongoing referral to ourselves, it should only be those patients who have an existing need and move into the area. So if it's a patient who's changed GP practice within the Bob area, they'll be part of the service anyway. So an onward referral isn't needed. It just tends to be patients who are outside of the ICB moving into the ICB that would need an onward referral. And even then, the amount of information that is required is very minimal. And it's very, very infrequent that happens based on our other services.
Yeah, I mean, there has been a referral form, as you know, that for referring into the service for nurses. We can make this available to practice via an open yourself.
Yeah, that would be helpful. Yeah. And Jennifer, I'm just confirming that your understanding the Bullen will email each surgery an SOP and instructions, etc.
So what we're going to do is we've agreed with Anoop that ultimately it will come from Anoop to provide that assurance of it's the ICB and it's not just some random company trying to get hold of patient data, because we know it may not always land with in the inbox with people who are present here and know about it.
And another one, just for confirming, if the practice carries on receiving a prescription request from DAC, should the practice just pass this on to Bullens or contact the patient?
Yeah, you can pass that on to Bullens for as soon as we hit the go live date. If you're a practice going live on the 6th of October, if you get prescription requests after that date, you can forward those into the service and we'll deal with them. We'll pick them up with the patient.
Thank you. And Jess wants confirmation that, can you clarify, once you reconcile repeats, will all stoma repeats be removed from our repeat list, or do we record them as hospital only prescribed or such for reference?
To be honest, it's entirely up to the practice. Most of the practices just go with that advice of add a note to the patient's record to say patient has a stoma, because what actual stoma bags a patient is prescribed doesn't really make an impact on their comorbidities. So it doesn't add anything beneficial to have it as hospital only, other than identifying that the patient has a stoma.
Okay, thank you. That's all the questions in the chat box, and I'll let you answer the questions from people who've raised their hands. Thank you.
Thanks.
Can I just go back to what Paul just said as well? But in terms of having a note on the patient that it's a stoma patient, that's ideally the minimum requirement. Or obviously, if you want to put it as hospital only prescribed, that would be good practice. And I think that's what's down to the individual practice to decide. But it's good practice to have them listed. Michael.
Hi there. Sorry.
Oh, sorry. Yeah.
I'm on my phone.
Oh, hi.
Sorry. Yeah, it all sounds really good. I'd say I'm a GP partner. I would say if we can make this as light touch as possible from the GP practice, you know, that 10-minute search, that sounds ideal. If we can do a 10-minute search and the patients then disappear off our prescribing list, that, you know, for those items, that would be, to me, the ideal. So my first question was, will the prescriptions that are on the patient's notes already of these stoma pieces of equipment, will data sharing mean that you can take them off without us needing to manually remove them? Will the patient still see them on current or past medications, and then they might try to request it directly or do something like that if the patient decides not to engage with Bullens? I don't know.
Yeah.
So I'm just wondering, is that going to be automatic on your end, or do we need to do that manually when the switch happens?
Yeah, unfortunately, it's not automatic, and we can't control that because we can't get access to your clinical systems. So they will fall off eventually. However, if patients do try to request them, and some will, and some DACs will continue to try and do it at the start until they get the message of, oh, actually, I can't circumnavigate this. I will just ultimately fall across. But we're hoping that that will be the exception rather than the majority of patients.
Okay. And then I guess the second thing was, if we have a new patient coming from another area, we need to do a referral form. Can I suggest that that referral form be as light as possible? Because we wouldn't have met the patient. We might have met the patient in an appointment, but we wouldn't have been privy to all the reasons on why they were on this specific appliance. So it makes more sense for us just to send you literally name of the patient, and if it's a stoma or catheter, and then probably your nurses are probably better suited to collect the information on how long they've been on it, what their supply is like, yada yada yada.
Yeah.
So
Yeah, all we need basically is patient's name and well, NHS number is sort of vital, and then a secondary reference source so we can verify, and then we'll pull all of that information from the patient summary care record from their previous practice, so we'll be able to see what they're on, but then they will be followed up by one of the nurses anyway, to be able to do that cross-reference and verification of you were prescribed X, Y, and Z. Is that what you're actually still on now?
Thanks, Michael. Any other
Yes,
questions?
care home patients are included. We've got slightly different process internally for care home patients. So what we will do is we'll work with the care home to attempt to do the stock check for all of the residents at the same time, rather than having potentially 20 residents and then ringing 20 times a month. We'll look to liaise with the care home manager or a nominated person to bring that care home and say, right, we're going to do the stock check now for your 15 patients, and we'll get it all done at once.
Thanks. And will that go live date be the same, 6th of October?
It will depend on the individual GP practices, but what we will do is once we start to get the care homes and the patient data across, we'll pull all of that together, and that's one of the contributing factors to why we have that hard stop date on the data, so that we've got it and we're able to do what we need to do with it before the actual go live date.
Okay, thank you.
Any more questions? Can't see anything else in the chat. Hopefully we haven't missed anything. You do have our the Bob ICB email address if you think of anything that you want to ask. Once we've left the meeting, you can always email it in through to us, and we'll respond to it. So as Paul and Jeremy have said, and we're just working on the final bits to get it ready over the next couple of weeks. Contracting the data sharing agreement, the DPIA. Once that's done, we'll write to each practice as part of cohort 1. And you'll get your go live dates. Ideally, the cohort 1 will be the 6th of October. Your letters or your emails will come out to you on by the 15th of this month, September, rather. and the data uplift from the practices needs to be back to Bullens by the 22nd, and 22nd will be the hard stop date, but we will confirm all those dates in the email directly to yourselves with the practices that are concerned in that cohort 1. Okay, if there's no other questions, thank you very much, Jeremy and Paul, and all of you for attending this meeting. Please do share with your colleagues, friends, staff, anyone that really needs to know about the change in the service for prescribing of stoma and catheters and urology products and trans products and anything else to do with appliance management within your practices. All right, thank you very much.
Thank you.
Thanks all.
Thanks. Thank you.